Prof. Asad, if you want to centralize your camera, please, Prof. Asad. And okay, we are ready to start, Prof. Shall I admit our guest?
Yes, yes. يا أبو عمر.
Okay, we can start, Prof. It's already live,
Yes.
and the guests are here.
So you want me to get started, or?
Yes.
Oh, okay. Sorry about that.
Will Dr. Ali, he's the moderator. You'll introduce Dr. Ali, I think, or?
Shall we start?
Yes.
Yes, yes.
Okay. Bismillah ar-Rahman ar-Rahim. Welcome everybody for the third day of the 9th Middle East course of Pediatric Gastroenterology, Hepatology and Nutrition. Tonight we have 2 sessions and 4 distinguished speakers. My name is Ali Al-Mahedib. I am a pediatric gastroenterologist at King Faisal Specialist Hospital and Research Center in Riyadh. And it's my pleasure to introduce our first speaker, Professor Alissu Fassanu. He is a professor of pediatrics and professor of nutrition at Harvard Medical School in Boston, as well as his director of mucosal immunology and biology research center at Mass General Hospital in Boston, United States. Professor Fassanu translational science is focused on the role of impaired intestinal barrier function in the pathogenesis of autoimmune and inflammatory diseases, including celiac disease, autism, and type 1 diabetes. He is the director of the Center for Celiac Research and Treatment, and he is widely sought after as an expert in celiac disease, intestinal permeability, and autoimmune disorder. And tonight, he will talk about a very difficult, subject, diagnostic dilemma in celiac disease. I'm sure it will be very interesting in this field. Professor Fassanu, the floor is yours.
Thank you, Ali, for the kind invitation. And again, my only regret is that I'm not, physically there, but hopefully better times will come for the future, so I will be physically there. I just want to make sure that you see my screen okay. Is that okay? I'm assuming that it's okay. As you heard, okay, as you heard, I was given the task of a very difficult topic. So diagnostic dilemmas and celiac disease. This is a brief review of my conflict of interests, companies that I have a relationship with in a different capacity, but we're not going to discuss any of this. When I was in training, I was taught that, if somebody needs to go on a gluten-free diet, it's because of celiac disease. And if celiac disease is ruled out, then there is no reason to be on a gluten-free diet. And the landscape now is very, very different. And as an example, I'm presenting you the trend over time of 3 different diets. The gluten-free diet is the one that we are really interested, compared to, the low-carb diet and fat-free diets in yellow and red, respectively. And you can see from this trend and from the map that we have right now in the United States that the gluten-free diet is extremely popular, to the point in which out of 3 people in the United States, so roughly 100 million people, would embrace a gluten-free diet. So if in the past, I may be guided by who's been on a gluten-free diet to have a sense who has celiac disease, now this is a dilemma in terms of who should be on a gluten-free diet and why. Because now it looks like there are many more people that embrace a gluten-free diet beside people with celiac disease. If we want to do a classification of who consume gluten-free products, and again, the gluten-free diet should be considered a therapeutic intervention for celiac disease, you see that there are 2 major categories. One that we don't care for the sake of the discussion today. So the people that embrace the gluten-free diet are not for medical necessity, but for lifestyle. And the one that we care, there are the ones that if they don't go gluten-free, they have consequences, they have symptoms, they don't feel well. And under this group, there are 3 subgroups. People that have an allergic reaction to gluten, so with allergy, there is a relatively rare condition. Celiac disease, that the object of the discussion tonight, that I'm going to focus mainly in terms of diagnostic dilemmas, and non-celiac gluten sensitivity or gluten sensitivity, the prevalence of which is still an object of debate because we don't have validated biomarker. All this to say that if I want to really do a diagnostic approach to celiac disease as we typically did in the past, clinical presentation that will guide me, and therefore a evaluation of the people that have celiac disease based on the therapeutic intervention of gluten-free diet, that's not the case anymore. So that can be only confusing and not guiding, in discussing, and identify people with celiac disease. If anybody is interested to get a little bit more in details on this, this is a review that we wrote for JAMA relatively recently that really overviewed this entire deal, but we don't have time to go through this. But this is just for your information if you want to get a little bit more insights of the diagnosis of celiac disease versus other celiac disease, gluten-related disorders, so to navigate how you make the differential diagnosis. But pertinent to celiac disease, if we had this discussion 10, 15 years ago, we didn't know exactly what kind of disease this was. That was considered, to be a food intolerance, a food sensitivity, and so on and so forth. Now we know that celiac disease is truly an autoimmune disease, and therefore has all the characteristics of an autoimmune process that is extremely important when it comes to diagnosis and therefore the dilemmas that we have with the diagnosis. It's an autoimmune disease, but with a lot of peculiarity. Peculiarity number 1, like any other immune disease, there is a genetic component. And specifically, there are some genes of the histocompatibility class, the HLA, DQ2, DQ8, that have a huge penetrance in this disease. Almost the totality of people with celiac disease will have either the DQ2 and or the DQ8. Compared to other autoimmune disease where the penetrance is 70, 60%, this makes a huge difference that we use for diagnostic dilemmas as we see in a second. The second peculiarity, also important for diagnosis, is the autoantigen is known. There is this intracellular enzyme that's called transglutaminase, tissue transglutaminase, or TTG for short. The third and probably most important peculiarity of celiac disease compared to any other autoimmune disease is the environmental trigger is known. We don't know what makes people sick with diabetes, multiple sclerosis, rheumatoid arthritis, but we know that gluten is the trigger, the culprit for celiac disease, and therefore its elimination will bring to a complete resolution of the autoimmune process if, done correctly. Now, the first major diagnostic dilemmas for celiac disease, it's this clinical presentation. Again, if you deal with diabetes, it's pretty obvious that, people that they drink a lot, they, go to the bathroom very often in terms of urine output, they have diabetes. But when it comes to celiac disease, the presentation of this condition is being really compared to a clinical chameleon. if you go to a classical textbook, you will now see that the concept of celiac disease, the way they present itself clinically, is conceptualized with this, concept of iceberg, in which the visible part are the people they have symptoms. They are typical of celiac disease. It can be gastrointestinal or extraintestinal symptoms. And here we already have some challenges there. But the vast majority of people with celiac disease are underneath the line of water, starting with silent celiac disease. These are people that they have the immune response. So in other words, they have the biomarkers that we will see in a second that we use for diagnosis. They have the autoimmune damage of the disease. So they have the celiac enteropathy if you do an endoscopy, but they don't have symptoms. So they are not visible because they have little or no symptoms. And the last form, that is called latent form, is the one in which they have the autoantibodies. Of course, the common denominator of all these people, they have to have the genetic susceptibility, but the mucosa is not damaged yet. So they are in a preclinical phase. Coming to symptoms, the classical way that disease presents itself is chronic diarrhea, abdominal distension, lack of appetite, failure to thrive. Well, this is a picture of kids with celiac disease in the 30s in London. And you can immediately appreciate a clinical dilemma here. If you have somebody in clinic like this, it will be very difficult to distinguish a kids with celiac disease versus, let's say, malnourished kids that have kwashiorkor. They look exactly the same. So the clinical presentation can be really deceptive. Talking about diarrhea, particularly in the Middle East, but also everywhere else in the world, distinguish a chronic diarrhea from infections to a chronic diarrhea due to celiac disease just on a clinical basis is not an easy task. So you can't rely just on clinic and clinical manifestation to make the diagnosis. To make the story even more complicated is that, yes, the celiac disease is an autoimmune process involved in the gastrointestinal tract, and therefore gastrointestinal symptoms, consequence of the damage to the mucosa, are the most frequent way the disease presents itself. But because it's an autoimmune process, and because the immune cells, when activated, they can go anywhere in the body, this is truly a systemic disease that does not spare a single organ or tissue in our body, particularly in older kids, but now we start to see also in the younger one. We see presentations that we used to call atypical, but they are not atypical. For example, iron deficiency anemia that resists to oral iron supplement. It's a very frequent way that disease presents itself, almost as frequent, if not more frequent, than gastrointestinal symptoms. Skin manifestation like dermatitis or herpetiformis, that this is blustery, a skin rash that was typical adults now are very frequently seen in kids. We see very frequently in kids the damage of the enamel of permanent teeth, what we call dental hypoplasia. Even in pediatrics, and this is counterintuitive, because of vitamin D and calcium malabsorption secondary to the enteropathy, we see osteopenia and sometimes osteoporosis. Another major problem that we see is short stature, so these kids are stunted. And once again, there is another additional challenge here because, stunting can be the consequence of malabsorption or environmental enteropathy that histologically is very similar to celiac disease. So another layer of complication in terms of diagnostic dilemma. And of course, with malabsorption comes delay of puberty, and I can go on and on and on. The point that I want to try to make is really based on a clinical manifestation. It's very difficult to think about celiac disease unless you are aware of the different way that disease can present itself. One district that is very much favored by the inflammatory process typical of celiac disease is the brain. And there are a lot of clinical presentation, they're associated to celiac disease that can involve in the brain. And just if you take a quick look at the way that disease can present itself with the brain involvement, chronic headache, short memory loss, anxiety, depression, autism, ataxia, seizures, irritability, you see that this is nothing specific that can guide the clinician toward the right diagnosis. There are people that may experience these symptoms for a long, long time before that we think that celiac disease can be at play, and therefore these kids will be screened for celiac disease. So the point that I'm trying to make is the first issue, based diagnosis on a clinical presentation will represent a major challenge. So as I told you, to addition, a challenge that we face, that based on the studies done in first-degree relatives, we know there is this submerged part of the iceberg. So in other words, these asymptomatic patients that can still at risk to develop, consequences if we don't diagnose them frequently and, promptly. And the asymptomatic kids needs to go on a gluten-free diet anyhow, because, they may eventually, over time, develop, symptoms, or if they have other pathologies like, this comorbidity, with other autoimmune diseases, or if they are first-degree relative of somebody with celiac disease. And talking about comorbidities, we know that there are some genetic disorders or syndromes that occur with celiac disease at high frequency, like, Down syndrome, for example. Many autoimmune conditions are in comorbidity with celiac disease. Typical in pediatrics is the comorbidity of a celiac disease with type 1 diabetes. And now we see a comorbidity with Hashimoto thyroiditis, even pediatrics. And of course, relative biopsy-proven celiac. Talking about numbers, the prevalence of celiac disease is roughly 1% of the general population, 1 in 20 roughly in first-degree relatives, and a little bit less in second-degree relatives, with many differences that are regionally distributed. Now, what are our tools in the toolbox that we have for diagnosis? The one diagnostic dilemma that should not be a dilemma is the screening tools that we have. So we have a series of screening tests. They are extremely robust in terms of sensitivity and specificity for celiac disease, particularly the last generation of antibodies against tissue transglutaminase. So the anti-TTG antibodies, they are really, really robust. They are automated. They are done by machine. So this is an ELISA test, will not require an interpretation of the operator. And they are very reliable unless, the subject has IgA deficiency, because of course, if there is IgA deficiency, these antibodies will be falsely negative. As an alternative, we have the IgG class of antibodies against DTG. They are not as robust as the anti-deamidated gliadin peptide, so the DGP IgG antibodies. You see by the numbers that there is wide variability in terms of sensitivity and specificity for the TTG IgG, depending on the kit that you use, but the DGP seems to be more robust. And then we have the anti-nemesium antibodies. They are really, really robust as well in terms of sensitivity, specificity, but they are operator dependent. So it depends on the skills of the operator, the interpretation. So that's a caveat of this test. Finally, the search for the HLA DQ2, DQ8 is extremely important for sensitivity. So in other words, to identify people with celiac disease, but not definitely specific for the disease. And I'm going to get back to that in a moment. Now, another diagnostic dilemma that we've been dealing with for quite a long time is that these are all screening tests. And even if they are really robust, they don't give certainty 100% that, the subject that tests positive has celiac disease. There is always a little chance of false positivity. And because this is a condition that will imply change in lifestyle forever, for the rest of the life. So we're talking about embracing a gluten-free diet that is not something easy to implement, particularly in specific socioeconomic situations. We want certainty, and that's the reason why we reflect after the test with an endoscopy to do a biopsy that show the classical damage of celiac disease. The challenge here is that there are two issues. One, the acceptance of an invasive procedure by the family. That it's particularly for younger kids, they are always a little bit, concerned in doing such a thing. But also the fact that there are realities in which a pediatric gastroenterologist may not be available or readily, available to do procedures, and therefore, the diagnosis really can be a major challenge if you have a practice with a 6 months waiting list and you can't keep the kids eating gluten for 6 months, or there is no pediatric gastroenterologist in the area. So for that reason, and also in light of new information that over time we've been accumulating, there's been a task and desire to find alternative solution to avoid, the performance of an endoscopy to confirm the diagnosis. And, the European Pediatric Gastroenterology, Hepatology and Nutrition, Society, a few years ago, came up with some revised criteria for diagnosing kids with celiac disease that need to fulfill the follow criteria to avoid an endoscopy. First and foremost, we're talking about only kids with symptoms. So this has to be done only in asymptomatic kids. So the asymptomatic, they don't apply to this protocol. And if you are asymptomatic, the first screening is the TTG test. If the TTG test is positive, and is positive 10 times more than the cutoff titer, then eventually this reflects with the anti-endomysium antibodies and the HLA genotyping. So if the kids has 10 times more the titer, needs to then reflect with the anti-endomysium and the HLA. If they both are positive, that confirms the diagnosis of celiac disease, avoiding the endoscopy. All the other scenarios there in this very complex algorithm, so less than 10 times, the titer, if the anti-endomysium is positive, but the HLA is questionable, or vice versa, that the HLA is compatible and the anti-endomysium is positive, will require a biopsy. So again, to summarize, symptoms, TTG positive 10 times more the norm, confirmed by anti-endomysium antibodies positive and HLA compatibility will lead to diagnosis of celiac disease without an endoscopy. Now, what we do for follow-up of these kids? In general, we use, the TTG for follow-up, beside, of course, the symptoms and so on and so forth. But now new data suggests that while this TTG is robust for diagnosis, when it comes to, monitoring, its specificity, its sensitivity are less than ideal. But this reflects with a poor positive predictive value, meaning if it's positive and I do an endoscopy, I find the damage there, not always so. So you can have false positivity, and we have kids for years that will stay positive for the TTG, but the endoscopy shows no damage and the symptoms are gone. But unfortunately, also the opposite, even more so, that you have negative, serology, but the damage is still there. So that's a clear dilemma in diagnostic and follow-up using these tools. I want to wrap it up with the HLA test. As I told you, the vast majority of people with the celiac disease, they have either both of this DQ2 or DQ8. However, you know, they are found also in the general population. So the presence of these genes, it doesn't tell me if you have celiac disease or not. But if you are negative for that test, my level of confidence that you are not celiac is extremely high, because it's almost impossible, you know, to develop the disease without this gene. So in other words, the HLA, they have a strong, high negative predictive value. And, you know, the lack of these genes most of the time rule out the diagnosis of celiac disease when we use this test, because this is expensive and we don't want to use, you know, all the time. The main reason to use them is in asymptomatic relative. In other words, if you have somebody in a family with celiac disease, we recommend the rest of the household to be tested. If they test negative, the question is, okay, but because there is familiarity here, how frequent I have to screen these kids for celiac disease? Well, the answer can come by doing the HLA DQ2, DQ8. If the HLA DQ2, DQ8 is negative, the answer is never. Maybe in exceptional cases, if the symptoms are, if these kids would develop symptoms that you don't have any other reason to explain the symptoms, but otherwise, you know, the absence of these genes is almost certainly ruling out celiac disease. If you have genetic conditions that comorbidity with celiac disease or autoimmune diseases, that's the time to do the HLA DQ2, DQ8. And in diagnostic dilemmas, many times kids that come to our practice that have been eventually put already on a gluten-free diet without confirming the diagnosis by either the classical device, the criteria, and the only way to do the diagnosis now to expose gluten, these kids to gluten again, and therefore induce, you know, a relapse of the enteropathy and so on and so forth. It is something that families are not really amenable to do all the time, because you have to make your kids sick again. The alternative is to do the HLA. If the HLA is compatible, then the chance that these kids have celiac disease becomes much higher, and therefore a gluten challenge will be appropriate. I will stop here with the diagnostic dilemma, and will give the my word and the floor to Ali again to introduce the next speaker.
Thank you very much for this excellent presentation, and we will move to the next speaker, Dr. Ruba Azzam. She is an associate professor of pediatrics, and she is the director of pediatric hepatology and medical director of pediatric liver transplantation program at the University of Chicago Commerce Children's Hospital. She had her medical degree from the University of Jordan in 1995, and she finished her residency in the University of Wisconsin in Madison and the pediatric GI and hepatology fellowship from Northwestern University in Chicago. Dr. Azzam then pursued her MPH degree from the University of Illinois in Chicago, and her experience and expertise in pediatric hepatology, she developed also an expertise in managing children with chronic pancreatitis undergoing islet autotransplants, and got appointed as the medical director of the pediatric pancreatic disease program at the University of Chicago. She will talk to us today about the management of chronic pancreatitis in children with total pancreatectomy and islet autotransplantation. The floor is yours, Professor Azzam. Thank you.
Thank you very much, Dr. Mahidab. Assalamu alaikum, everyone. Thank you very much for the invitation, and I would have loved it to be in Riyadh, but subhanahu wa ta'ala, inshallah, next time. So I'm gonna share my screen. All right. So today I'm gonna be talking about chronic pancreatitis and total pancreatectomy with islet autotransplantation in children. I have no disclosures. I'm going to start with a case presentation that illustrates the process or the spectrum of diseases that patients with pancreatitis could go through. And then I will review with you the consensus statement from the INSPIRE group on the causality of acute recurrent pancreatitis and chronic pancreatitis in children. And then I'll go over the management of chronic pancreatitis medically, surgically, and then the treatment with surgical total pancreatectomy and islet autotransplantation, and describe some outcomes. So this is a case that was referred to me a year and a half ago almost. She was a 13-year-old adolescent girl who was referred for recurrent abdominal pain for 3 years. Her pain was the usual for pancreatitis, pancreatic inflammation with epigastric to left upper quadrant pain that radiated to her back with nausea and vomiting and no fever, and symptoms would last for a few days to a week and then recur every 2 to 3 months. There were no precipitating events that she could tell, and there was no significant medical, surgical, or family, and the girl was from Macedonia. So this girl really illustrates the typical scenario that we have patients with presenting with acute pancreatitis. Between her symptoms, her pancreatic enzymes were significantly elevated, both amylase and lipase. And when we did an ultrasound, we saw the enlarged pancreas with different echogenicity than normal, the edematous pancreas, and she fulfilled all the criteria that we need to diagnose anyone with acute pancreatitis, though the diagnosis could come with only 2 out of the 3, and these are the characteristic abdominal pain, pancreatic enzymes at 3 times upper limit of normal or more, and imaging consistent with acute pancreatitis. And then she continued to have these episodes of pain every 2 to 3 months. And she had more imaging, this time with MRCP, and it was normal. So now she qualified to get the diagnosis of acute recurrent pancreatitis, which is at least 2 discrete episodes of acute pancreatitis in the absence of evidence of irreversible structural changes in the pancreas. And then her story continued with more pain between even the episodes of the discrete episodes of pancreatitis, and these episodes started becoming closer. She had an MRCP, and now her pancreatic duct was irregular and abnormal. She had no other symptoms, though her growth started slowing down, and her pancreatic endocrine sufficiency was still preserved. So with that, she got the diagnosis of chronic pancreatitis. So what is the definition of chronic pancreatitis? It is the irreversible structural changes in the pancreas, such as diffuse or focal destruction, sclerosis, or pancreatic duct abnormality with at least one of the following: either that they have abdominal pain or lipase and amylase 3 times upper normal or more, or they develop exocrine pancreatic insufficiency or endocrine pancreatic insufficiency. So what do we know about pancreatic diseases in general in children? These are relatively rare in childhood, and acute pancreatitis affects roughly 1 in 10,000 children. About 15 to 35% will go on to develop recurrent episodes, and a small portion of these will have chronic pancreatitis development over time, and this is possibly less than 1 in 100,000. Although the adult groups usually see a lot of pancreatitis precipitated by alcohol and gallstones, we see less of these, though nowadays with obesity, we've been seeing biliary pancreatitis quite often at our hospital and probably in the whole world where obesity has hit. And the etiologies are very wide, but many of them stay idiopathic. So is there a link between acute recurrent pancreatitis and chronic pancreatitis? We know that toxic and metabolic factors are very common precipitants of acute recurrent pancreatitis, but we also know that the genetic factors are more commonly found in patients with chronic pancreatitis. And many patients, pediatrics with chronic pancreatitis and acute recurrent pancreatitis have common etiologies. I'm going to skip to what we've learned from the International Study Group of Pediatric Pancreatitis in Search for Cure. This is a consortium that was formed in 2009, mainly from North America, but with few countries from all over the world. They basically collected data from doctors, gastroenterologists, and families of patients who developed acute recurrent pancreatitis and chronic pancreatitis. And the goal is to fill the gaps in knowledge and improve clinical care. So we learned from them that the evaluation of acute recurrent pancreatitis and chronic pancreatitis should include evaluation for the anatomy of the pancreas, metabolic disorders, and genetics. Just quickly over the anatomic, I think we all have learned from medical school even about pancreatic divism. So we know that this is the failure of fusion of the anterior and posterior ducts of the pancreas. So this is diagnosed by MRCP, and we know that we usually, any patient who has recurrent pancreatitis, we do get them more than just an ultrasound. So usually they undergo MRCP or secretin stimulated MRCP, sometimes EUS or even ERCP. One thing to remember all the time is that patients who develop pancreatitis and present to you with pancreatic enzyme abnormality and the diagnosis fulfills for pancreatitis, but you notice that their LFTs have a GGT of 2 times upper limit of normal, those patients, or direct hyperbilirubinemia, they definitely need an MRCP to further evaluate the causality of their presentation. We know that pancreatic divism is present in about 8 to 9% of the population. And at one point, it wasn't thought of as a precipitant for recurrent pancreatitis or chronic pancreatitis, but we got new knowledge from the INSPIRE group about what they found in the patients who had recurrent pancreatitis and chronic pancreatitis in children, where about 15% of them had this abnormality without any genetic background. Metabolic etiologies, we commonly do fasting lipids, of course, calcium level. When we think about metabolic diseases, we also think about organic acidemias, so serum ammonia and urine organic acids, among several others. Moving to genetic etiologies. So this is very, very important for patients with recurrent pancreatitis and those with whose first presentation even is chronic pancreatitis. So checking for a mutation of PRSS1, SPINK1, CFTR, and CTRC are very important. We have them in one panel at our hospital, and possibly it's the same all over. We definitely have to make sure for patients who have this problem with the pancreas that even if their newborn screen was negative for cystic fibrosis, they get still fully evaluated for CF. So why are these mutations important? So we know that trypsinogen is a precursor for trypsin, and it needs to be activated. So the PRSS1 is important for this, then this cannot happen. We know that trypsin needs also to be degraded, and the enzyme responsible for this is the chymotrypsin, and the gene behind it is the CTRC. So if there is abnormality in that gene, then or mutation, then there is also more trypsin degradation. And lastly, SPINK1, we know that trypsin leads to inflammation and injury of the pancreas, and this is prevented by SPINK1. So if there is loss of the function of SPINK1, then there is definitely injury and inflammation of the pancreas. All right, so there was one study of pediatric patients, 170 of them, who had chronic pancreatitis, looking at the etiology of their chronic pancreatitis. And one or more pancreatitis predisposing genetic mutations were found in 67% of these subjects. But 17% of the subjects in general did not have genetic tests done. So that means it's possible that there were more than 67% of the subjects with genetic background. And most of the abnormalities were for PRSS1, followed by SPINK1, followed by CFTR. Few things to remember about these genetic abnormalities. For example, PRSS1 mutation leads to hereditary pancreatitis and has a very high likelihood for progressive disease and even pancreatic cancer. We know that the disease penetrance of PRSS1 mutation is quite high, and we also know that we should be counseling all the family members. SPINK1 is also a PN34S. This variant is a risk factor also for rapid progression of chronic pancreatitis, especially if it was biallelic. And we know that having just a monoallelic SPINK1 variant with another variant of genetic mutation can predispose for cystic fibrosis, like one SPINK1 and one CFTR. So moving on to more of just chronic pancreatitis. So we know, if any of you had patients with chronic pancreatitis, you know how debilitating the disease could be. And we do not have exact data about the prevalence and incidence of that, but there was one single center that estimated that 9 to 35% of children with acute pancreatitis will go on to have recurrent episodes. In the young adults, we know that the incidence of chronic pancreatitis was about 0.5 per 100,000 persons per year, and that takes it to about 4 to 10 in 100,000 per year in the general population. We know patients with chronic pancreatitis are at risk for pancreatic adenocarcinoma with a relative risk that varies between 2.3 and 18.5. Clinically, they have severe pain that may lead to narcotic dependence. They may develop chronic steatorrhea over time and failure to thrive. 1/3 of them will develop endocrine insufficiency as well, and strictures of the common bile duct and pancreatic stone formation are also some of their presentation. The disease burden, though, is very high. Those patients have so many ER visits, hospitalizations, they miss school, and they undergo a lot of endoscopic and surgical procedures to relieve their pain. Why do they develop pain? There are several etiologies. So you can think about the pancreatic duct obstruction and the increased pressure over there. You can think about the inflammation that leads to ischemia of the pancreas. You could think also about the neuronal inflammation of the nerves that supply the pancreas. Pseudocyst formation and pressure, and duodenal and common bile duct obstruction can add also to the significant pain that those patients have. How do we manage them? The medical management starts with pancreatic enzyme supplementation, antioxidants, and escalating pain management, where over time, very sadly, many of them become opioid dependents. Some patients will undergo endoscopic intervention to remove a stone or achieve pancreatic duct decompression. And a few of them are referred for surgery with a major objective of relieving the pain and improving the quality of life. Secondary goals are preservation of the endocrine functions and preservation of the exocrine functions of the pancreas. So some patients will undergo partial resection or drainage procedures. And we know that even with those procedures, patients will have transient pain, and that about half of them will go on to have the pain again and will continue to get exocrine and endocrine insufficiency over time. So is radical total pancreatic resection is the treatment. So this for sure will relieve all the pain that is related to pancreatitis, but of course that will get those patients to lose their endocrine and exocrine pancreatic functions. So back in 1977, a very smart surgeon, Dr. Sutherland, reported on his experience using islet cells from cadavers of infants and adults. He took their pancreatic tissue and used it as infusion in patients who underwent kidney transplantation and developed diabetes. So there were about 7 patients, and he infused those islet cells either into their liver or left them in the pancreas, and one got it intramuscularly. So those patients, no one get their diabetes cured, but many of them had decreased need for insulin. And there were, of course, many lessons that were learned from this experience. Over time, Dr. Sutherland started a big program at the University of Minnesota for total pancreatectomy and islet autotransplantation in both adults and in children. And this is one of the reports that they had on the first case. It was back in 1996 of a boy who was 12-year-old with idiopathic chronic pancreatitis. He developed complete relief of abdominal pain after such surgery, and he remained insulin independent for some years before he needed some insulin back in his regimen. So that gave an idea about what indications should surgeons and the medical team have for referring patients with chronic pancreatitis. So the indications for such surgery are chronic pancreatitis with intractable pain that is resistant to medical, endoscopic, and other surgical therapies. Usually those patients are the ones with small duct disease or those with hereditary pancreatitis. And the primary goals are relieving their pain and restoring their quality of life. Possibly, there is a potential that this also eliminates the risk of pancreatic cancer. So this surgery is of two parts. The first one, so there are two teams of surgeons, basically. The first one is removal of the pancreas and reconstruction of the upper GI system. And the second one is preparing the pancreatic islet cells and infusing them back in the liver. So I'm gonna show you how that happens very quickly. So we need, of course, special labs for such retrieval of the islet cells. And the goal is to get those islets of Langerhans out of the pancreatic tissue, leaving behind the exocrine portions of the pancreas. So basically, the pancreas is infused through its pancreatic duct with collagenase. So that makes the pancreatic tissue of course, get infiltrated and loosened up. And then whatever comes out of that goes into a special chamber with marbles at a certain temperature with a lot of agitation to help separate the cells. And then those cells are cooled down and are collected basically to get some liquid solution of pancreatic islet cells in a mixture of exocrine tissue. So in the amount of the tissue that is retrieved varies by how healthy the pancreas is. So the healthy pancreas will give an amount of 20 to 60 ml of tissue. And the unhealthy pancreas, where it's necrosed, will give a much smaller pellet that has fewer number of islet cells. And then that solution is brought back to the OR to be infused. Usually it's a mixture of the pancreatic tissue, the islet cells, and heparin and albumin. And then it's brought back to the OR to be infused. The surgeon will infuse it in the portal vein, paying attention to the portal pressure and giving it in aliquots. And of course, if the portal pressure goes elevated, then they take a break and measure it again. If it went down, they infuse a little bit more. But if it stays elevated, then they stop infusing in the portal vein, and whatever tissue they still have will be left in the peritoneum. What happens after that? Those patients will have much improved requirement for narcotics, and they will kind of quickly move on from IV narcotics to oral narcotics, and over time they will wean off completely. Endocrine function, during the first 3 months after the surgery, nearly all patients receive exogenous insulin, and that's the time to relieve the beta cell functions from the stress of the engraftment. The engraftment itself happens at around 75th day post-surgery. The diet is advanced, and they will have follow-up at 3, 6, and 12 months to assess their endocrine function. The exocrine function, of course, is completely lost. So they will have to be on pancreatic replacement therapy. They have their fat-soluble vitamins measured and supplemented as needed. And again, they are very closely monitored by the medical team and the dietitian working with the medical team. This first report, I'm going to go through 3 experiences. 2 of them are from the University of Minnesota. They were, and probably they are still the biggest in the country, but they started before all of us. So they had higher number in their registry. So the first report is about 75 children between 1989 and 2012. The mean age was 13.8. 36% of the kids were less than 12, and 64% were between 13 and 19, and almost half of them had pancreatic hereditary pancreatitis. 28% were idiopathic, and 5% cystic fibrosis. The abdominal pain was experienced for 7.5 years. On average, chronic pancreatitis, 5.7 years on average, and narcotic use for almost 2 years on average. This first figure here shows you the improvement of the pain. So from 100% down to almost 0 in the first year, and much of the improvement of the pancreatic pain happened in the first 3 months. After that, they maintained lower prevalence of pain between 10 to 20%. And of course, there were other pains that mostly were incisional rather than anything else. For insulin independence, about 41% of the patients developed insulin independence over almost 3 years. But it was important to mention that 90% of the ones who achieved insulin independence did that within the first year. And if we regrouped these patients to separate the younger from the older ones, we see that the younger ones had higher prevalence of insulin independence, reaching 56%. And this insulin independence was observed for as long as 10 years after the surgery. So the factors that were important in predicting insulin independence were younger age, younger than 12, no surgeries on the pancreas before, lower BMI, more islet cells infused, with children receiving more than 2,500 islet equivalents per kilo were more likely to achieve insulin independence, the total amount of the islet equivalents transplanted, and there were more boys achieving this more than girls. So the conclusions of this report was the timing was very important, insulin independence happens, and the operative morbidity is low, and the surgical complications were minor compared to how big the surgery is. Then the same group reported on a smaller group of patients who were between the ages of 3 and 8. And again, genetic factors more than anything else. And their outcomes showed that how much of improvement in the hospitalization rates those patients have. So from an average of 5 hospitalizations per person per year of follow-up to 0.35 hospitalizations per person per year. And 8 of the 20 readmissions occurred in the first week, 8 weeks, and these were related to feeding tube dysfunction, constipation, or bowel obstruction concern that was ruled out. Again, they showed significant improvement of their need for narcotics. 17 were off all opioid at 1 year post-surgery, and patients discontinued both scheduled and intermittent oral narcotics by a median of 68 days. And by 6 months, they all discontinued the narcotics. Insulin independence, 82% had any period of insulin independence, 64% were insulin independent at the last follow-up of 4.2 years. Their growth parameters also showed significant improvement for weight, height, and the BMI, of course. And the conclusion was that this surgery is safe and successful, even in smaller children, and there was excellent pain relief and good islet graft function. So the age and size of those children should not be a negative factor for referring them, thinking that the surgery cannot be done. All right, I will last end with our experience. So we do the same surgery. We have 3 surgeons. 2 of them do the pancreatectomy, and Dr. Witkowski is the islet cell expert. And of course, we work hand in hand with the pediatric endocrinology team. We are one of 9 centers in the United States that does this surgery. And we recently put together our outcomes for pediatric patients who underwent the surgery between December 2009 and June 2020. And the follow-up was about 4 years. So we had 12 patients. the median age was 11. We really, at the diagnosis, and the age at the transplantation, median of 16, we really did not have very young children, as the second report that I mentioned to you had. 7 males, 5 females. BMI was 21 with a range of 17.5 to 33. So we had a couple of patients who were obese, and most patients had genetic mutations. One patient had autoimmune pancreatitis. 2 had idiopathic pancreatitis, and insulin requirement before surgery was seen in 1 patient. And then we also, of course, documented how many islets they got infused into them. So we saw significant opioid requirement decrease in the first 75 days. At 1 year post-surgery, 36% of patients had any kind of pain that needed intermittent opioids, but pain was non-pancreatic of origin or description. All patients reported, of course, significant improvement in their quality of life, and regardless of whether they needed insulin or not. This shows the insulin requirement and glycemic control of our patients. So before surgery, 92% of them were insulin-free. As I said, 1 of them was already on insulin. And after surgery, on day of engraftment, 2 of the 12 did not need any insulin. 4 of the 12 had an ANC of less than 6 and insulin requirement as minimal as less than 8 units. And over time, the patients who had continued to follow up with us, we see that there is an increased number of them reaching insulin-free era for them. So we also noticed that the insulin independence was associated with 2 main factors. The first one was the lower BMI. All patients with a pre-surgery BMI of less than 23 achieved insulin independence at some point. And that was compared with patients who had a BMI above 23, where 0 of them developed that over time. Over the time of follow-up, of course. And of course, the amount of islet equivalents per kilogram was important. So all patients who received more than 2,000 of the islet equivalent per kilogram developed insulin independence. We also, as other reports, noticed that the longer the duration of chronic pancreatitis was going on for, of course, the lower the islets that are retrieved. So in summary, total pancreatectomy islet autotransplantation offers pediatric patients with chronic pancreatitis resolution of pain and significant improvement in their quality of life. The surgery effectively preserved the beta cell function after total pancreatectomy, allowing for insulin independence in about 40 to 50% of pediatric patients, and stable glucose control with insulin support and partial islet function in the remaining ones. Insulin independence correlates with a shorter duration of chronic pancreatitis pre-surgery, higher islet transplanted mass, and lower BMI. And of course, the success of this surgery depends on the experience of the center, the degree of pancreas damage due to inflammation or previous surgery. And with that, I end.
Thank you very much, Dr. Roba, for an interesting presentation. And this will open a hope for some of these patients who are suffering really.
Sure, inshallah.
A few patients who are suffering, and we are suffering with them also.
Inshallah, inshallah. The earlier, the better.
With the questions, the first question to, yeah, that's true. Yeah. The first question to Professor Fasano, if you can hear me.
Yep.
Patient known to have A-gamma globulinemia and symptomatic, how would you reach a diagnosis of celiac disease if they have, low IgG, low IgA?
Well, these are the kind of situation in which you really need to rely on clinical presentation and endoscopy. There is no other way around. You don't have the screening tool anymore because, there is no humoral immune response that can guide you. So it has to be based on a clinical presentation and confirmation of the autoimmune insult by endoscopy, because again, the next step, if you make the diagnosis, is a lifelong gluten-free diet. You can't base that just on clinical presentation for the reason that I mentioned.
So would you go with biopsies if you have a clinical suspicion?
Yep. It has to be clinical presentation, so you have to have the clinical suspicion, and then I will go with endoscopy with biopsy.
Okay. Another question which does not, relate to diagnosis about, the celiac vaccine. Any news?
If you are patient, you will hear that in my second talk, that is the therapeutics, but there is a lot that's going on. So I will cover some of that, and if still not clear, I will expand.
Okay, that's great. We have quite, some questions to Dr. Roba. And I see many children and young adults with chronic pancreatitis who reach after many years of chronic pain. How do you see the future of them? How do we spread awareness outside the tertiary care centers?
So it's very important to know that there is a surgical treatment that helps those patients. I think many of the people are not aware of this kind of surgery, the total pancreatectomy and islet autotransplantation. So it's important to get the knowledge out and to refer these patients to the centers that could help them. From our experience and the experience of others, there is a significant improvement in quality of life for them. And also, if we could protect them from the development of pancreatic cancer, that is also a huge thing to consider and concentrate on. But it starts with awareness of the general, maybe pediatric and internists who see these patients, so that they refer them as early as possible and not wait for them to become opioid dependent. We sadly got a few who were already opioid dependent, and it was quite a struggle. But alhamdulillah, we were able to help.
And, another question, some patients with chronic pancreatitis, they got admitted for irritability. And when they check amylase and lipase, amylase is high, more than 3 times normal, and lipase is normal. And even imaging may be normal. So how do you interpret this?
So in chronic pancreatitis, the pancreatic enzymes are not reflective of what's going on. So it's exactly like cirrhotic liver, where the hepatocytes cannot release more. That exactly happens to chronic pancreatitis. So they are of no help when they are checked. You need to concentrate on the clinical presentation more than the lab values at that point.
Question to Professor Fasano. In regard to asymptomatic patients, we see a good number of asymptomatic patients referred to us from endocrine clinic with short stature or even diabetes, Down syndrome. And it's very difficult to convince family to go for, testing, or even, if they are positive, is to go for gluten-free diet.
Yeah, this is a major challenge because, of course, now you are not treating anything, you are preventing it. And, the intervention for prevention are less popular than intervention for treatment. So particularly for teenagers, when they have a say on the matter, if you don't get anything out of it, it's very difficult. Personally, I believe the only serious way to approach this is to lay out the facts, what is known in terms of the consequences, even if you don't have symptoms, to not embrace a gluten-free diet, and explain, objectively the pros and cons. And of course, in a situation which the family as a whole needs to be invested to implement the gluten-free diet, that has to make the final decision.
One of the difficult, things we face in our practice is compliance. And even those who are, symptomatic and they have celiac disease, it's very challenging. I don't know about, the compliance in the United States. Is it good or?
No, well, this also will be touched upon a little bit, on the next, discussion. The compliance is a major problem. Because again, everybody can appreciate that if you have a disease that will require a drug, a pill or an injection, has a much stronger message to send than a diet that is considered something more flexible in embracing. But at the same time, diet also implies a tremendous change of lifestyle. Again, I will going to touch upon at the next lecture. While you maintain your lifestyle, you take a pill or you take your insulin. It is a major challenge, no question about that. And that's the reason why, despite that the gluten-free diet is effective in most cases, not all, in most cases to control celiac disease, there's a huge desire of something else, a treatment, complementary alternative to the gluten-free diet.
Another question to Dr. Roba about acute pancreatitis, actually. If you have, a patient with acute pancreatitis, is MRCP enough to rule out any anatomical abnormality, or we have to do ERCP even in case of normal MRCP? I guess maybe.
So it depends on the cause of acute pancreatitis. So patients who have their first episode of acute pancreatitis with no biliary marker abnormalities, and they live in not too close area to big hospitals, then you do not even need to do imaging. But say this recurred, then at that point, yes, they need further evaluation. But say the first presentation was biliary pancreatitis. So that means D-bili was elevated, the ALT and AST were elevated, the GGT was elevated, then yes, this patient needs first an ultrasound to look for gallstones, biliary stones in the common bile duct, and evaluate the pancreatic tissue as well. And then they need an MRCP to localize where the stone is, if there is one. And then we refer them after that to the ERCP team. So if the MRCP does not show dilatation and no stone, then they definitely do not need ERCP. But if there is a stone stuck in the common bile duct, then those are the patients who need ERCP. At least at our hospital and probably many other hospitals, the ERCP team would not do an ERCP without an MRCP documenting the need for the ERCP, because we know that patients with pancreatitis undergoing ERCP have a 10% higher chance of moving from just acute inflammatory pancreatitis to necrotic pancreatitis. So they definitely do not go for it unless they have a clear indication. And many times they start even with a EUS to locate the stone and look at the area much better than the regular ultrasound or even the MRCP, and then they advance with ERCP. So not every acute pancreatitis needs MRCP, not every MRCP needs ERCP, and no ERCP without MRCP.
Thank you very much, Professor Fassano, Dr. Roba. I think we are running out of time and we need to stop here. We have a lot of interesting questions. Maybe we can share it with you both through email. And I would like to thank our attendee for their, interaction. And I will stop here. And for the next session, Dr. Sharif Al-Ghamdi, pediatric gastroenterologist from King Faisal Specialist Hospital and Research Center in Al-Madinah Al-Munawwara, is going to moderate the next session. Thank you, everybody.
Thank you.
السلام عليكم. وعليكم السلام ورحمة الله دكتور مامون. السلام عليكم بروفيسور سعد.
حياك الله بروف مأمون، فرصة طيبة.
مرحبا بك.
الله يحييك ويسلمك.
دكتور علي كيف حالك؟
بخير وعافية الله يبارك فيك.
بروفيسور سعد معنا دكتورة شريفة ولا مش موجودة؟ بروفيسور سعد؟
Prof. Mamoon, I think Dr. Sharifa, she's not around. I think you will be the one who will moderate this session.
Inshallah, inshallah. Shall we start now?
Yeah, the floor is yours. You can start.
Thank you. Thank you. I would like to thank Professor
Actually,
Asad.
I would like to thank Dr. Mamoon for accepting the invitation, being a moderator in a very, very short time. Actually, Dr. Sharifa obliged because she developed acute laryngitis and she lost her voice. Dr. Mamoon, he established this course, the first course with us in 2012, and really he's one of the cornerstone of this course. I would like really to thank him for his great effort in establishing this course over the last 8 years, and this is the 9th year. I would like also to thank Aliso and Dr. Aroba for the excellent presentation, and hope to see them on site next year. Dr. Mamoon, okay, welcome.
Thank you very much, Professor Asiri, and it was a pleasure to see all of you and to see other colleagues as well, and to remember the days of the course when we used to run it there. And it's a great pleasure to be with you today. I think our first speaker will be Professor Alessio Fasano. As you heard earlier, he's a reference in the field of pediatric immunology. He's the chair of the mucosal immunology, and he has extensive work in the pathophysiology of intestinal barrier defects in the pathogenesis of many autoimmune diseases. And he's one of the world leader in the field of celiac disease. So it's our pleasure to have him to talk to us again about new non-gluten-free modalities of treatment in celiac disease. Welcome, Professor Alessio again, and the floor is yours.
Thank you so much again for the kind introduction. And again, we will follow on what we were discussing before, as I mentioned also in my brief comments to some of the questions, on a new frontier in the field of celiac disease, but I was saying in autoimmunity in general. And let me start by saying that, it was one of the discussion and the question, compliance is a problem on a gluten-free diet. The pros of the gluten-free diet, of course, is efficacious, but not always, as we believed before, because now there are data in pediatric as well that roughly 20-25% of kids and up to 40% of adults, despite to be strictly gluten-free, no cheating, they still have enteropathy and there were symptoms. And, this can increase the risk of long-term consequences. Of course, the gluten-free diet is safe because there's no side effects, but, socially difficult, if not impossible, to implement, with accuracy forever. The gluten-free diet is not a pharmacological intervention, and therefore it's a good thing, but as a cons is that you have to pay for it, and the gluten-free diet is more expensive than a normal diet counterparts. Of course, you don't need any prescription. You can take care of yourself, but that means also as a cons, there is minimum medical support and poor regulation in different countries. The regulation are different. Is a treatment for celiac disease, but as a cons, right now, literally, there are no other options. Either that, or you don't have any alternative. It is life-saving, the gluten-free diet, but of course, it has a high burden on people, as you will see in a moment, that will really justify why people are looking for something other than a gluten-free diet. First of all, as I told you, it's not completely efficacious as we believed before. 30% of patients with celiac disease have persistent signs and symptoms of the disease after a year. And they are considered the vast majority non-responsive celiac disease. The refractory celiac disease that is extremely rare and is not premise of pediatrics, so we don't care that much because, with the exception of very rare circumstances, we don't see refractory celiac disease in pediatrics. And again, the data in adults, it's pretty compelling that that's the persistence after to 40%. And as I told you now, we're accumulating data in pediatrics that a non-negligible number of kids, despite strict gluten-free diet, still have an enteropathy and symptoms. And again, the compliance of the diet has a lot of issues. And again, to echo one of the questions, how you do that, how you maintain that compliance with rigor for the rest of your life. And particularly in kids, besides the same challenges that adults they have, including cross-contamination while traveling, vacation, and eating, and so on and so forth, the kids, they have these additional unique challenges to make the compliance of gluten-free diet very, very difficult. Birthday parties, school lunch, sleepovers when you travel, but most importantly, peer pressure. You don't want to be different as a child. You want to blend with the others. And the fact that you eat differently will make you weird and therefore less acceptable by your peers. Of course, there is lack of appreciation up to a certain age of long-term consequences for any kind of dangerous behavior, including not sticking to a diet. And then, in many parts of the world, when you go to school and you have now to cut your umbilical cord to your family that look after you in terms of the diet, and now you are in charge, and that really poses an additional challenge to stick with the program to stay gluten-free. And then if you ask, people with celiac disease, are you satisfied with gluten-free diet? Very, very few people. They said that I'm really satisfied with the diet. The vast majority, they said, their satisfaction is very poor or average, but very few, they say good or excellent. And if you look, the reason why people are exposed to gluten, the vast majority, they are exposed not knowing that. And so the reality of the story is, with all the intention that I have to do this right, I still have this risk to be exposed to gluten. Where are the the sign and that there's persistent villus atrophy in adults, the symptoms and the serology, the kids, of course, the same story. But the reality, there is the fact that despite all this, as I mentioned in my previous lecture, the screening tools are not as robust to tell me who still has, villus atrophy as, make the diagnosis at the beginning. So what are the consequences that we can advise as somebody that have, persistent enteropathy, besides the symptoms? Growth failure, nutrition deficiency, the fact that you have a chronic inflammation can affect, the school performance, definitely peripheral neuropathy, dental enamel defects, and so on and so forth. But the key question is, well, if I done everything under the sun and I stick with the program, I stay gluten-free, I still have the problem, why bother if I don't have an alternative? What else I can do? Well, the vast majority of patients, they cry out, they want something else. Not only for the stuff that cannot be controlled, but also because they want a better quality of life. The current available options that we have is this gluten contamination elimination diet that we implement in those that, despite sticking with the program, they still have an enteropathy with symptoms, or a steroid treatment like budesonide, to put the inflammatory process, under control for a certain period of time. But the future, the one that, again, was the object of another question, is, there is anything else in terms of treatment, including a vaccine and by induced intolerance and so on and so forth. So, yeah, there is now a growing number of initiatives to find something alternative or complement to the gluten-free diet, with this four main indication. Treatment for those that, despite staying gluten-free, again, they have ongoing signs and symptoms, non-responsive celiac disease or refractory type 1 and 2. It's something that can be adjuvant to the gluten-free diet for patients that are feeling well, to prevent, to have a safety net when they travel, for example, and they are not sure 100% that they are safe in going to a friend's house or traveling on vacation and so on and so forth. So they want to make sure that they are protected. Of course, the ideal is to say, forget about the gluten-free diet. Let's do something else, an alternative gluten-free diet. It is particularly helpful for patients with comorbidity like type 1 diabetes. Already they have to be on a restricted diet for the diabetes. Now, on top of that, they have to be gluten-free as well. And these two diets, they don't always are compatible with each other. Holy Grail, and we want to touch upon very briefly, to prevent the celiac disease to occur in kids that are genetically predisposed to it. I want to make a disclaimer. There are many stuff on the market now, and here are a few examples that promise that if you take that, you will be protected against cross-contamination with gluten, and therefore you have this already available. That's absolutely not true. These treatments are not validated. They are not being going through the scrutiny of gluten of clinical trials, and therefore the honest answer right now, if anybody comes to your office and said, I heard that there is something already available to, eventually help me with the gluten-free diet, the answer is no. There is nothing else to the market. So far, the gluten-free diet is the only way that we can treat people with celiac disease. Nevertheless, as I told you, there are a lot of stuff ongoing. Some for the prevention, some for alternative treatment to the gluten-free diet. In order to frame this correctly, I want to very briefly remind you the status quo. What is the current state of the art of knowledge of the chain of events that I depicted this cartoon from 1 to 6 that leads to celiac disease in somebody that's genetically predisposed? First of all, you ingest gluten-containing grains. We know that gluten cannot be completely digested. Some of these undigestible fragments, they interact with the gut mucosa, among the other stuff, induce an increased gut permeability by releasing this molecule that's called zonulin. This allows from number 1 to go to step 2. This fragment can have access in the lamina propria. This will activate the innate immune system that eventually increase the amount of intraepithelial lymphocytes that start the next chain of events in which now there is damage of some cells, the tissue transglutaminase leaks out of the cells that together with the gluten fragment that now are in the lamina propria will be deamidated and will be presented, the antigen presented cells that will activate the T cells that eventually lead to the tissue damage typical of celiac disease. These are the events. And therefore, these 6 points are all 6 points of possible interaction and attack that can be targeted by treatments alternative to the gluten-free diet. If this is not up to date, but it's relatively recent review of all the registered clinical trials for celiac disease on clinicaltrials.gov. Of the 260 trials, roughly 180 are for intervention, 150 of these 180 are pertinent to celiac disease, so of this discussion. And if you exclude the dietary intervention that we're not going to discuss and the prevention that we touched upon very briefly, we're left with a little bit more than 110 pharmacological interventions. Some are completed, some are still active right now, that really target any of the 6 points that I showed you before. To give you a snapshot where these clinical trials are up right now, there are many more, of course, in early phases, phase 1, that there are in total 25, with 7 they are actively recruiting, early phase 1, and then the phase 1, 33, with 2 recruited, phase 2, 3, the 2 recruited, and then the phase 3, there is only 1 that is now in phase 1 that is currently recruited. So there are a total of 52 active trials, of which 13 are actively recruiting. This is the map where these trials are occurring. Some of them are in the Middle East, 10 of them over there. So, the vast majority Europe or North America. This is a very busy slide, and I don't want you to be overwhelmed, but I want to just show you on the left-hand side of the slides the major categories of the current treatment alternative or complement to the gluten-free diet that are currently evaluated. starting with steroids. Of course, you know, this is an inflammatory process, so an anti-inflammatory drug can do the trick. But peculiar celiac disease, the glutenases, so in other words, enzymes that contrary to us, our enzymes are capable, these are mainly bacteria-derived enzymes, are capable to completely dismantle the undigestible gluten fragments that we have present in the GI tract that can eventually instigate the immune process. Using these enzymes from bacteria can eventually dismantle and disarm, therefore, these fragments that create, you know, the syndicates to avoid the damage. The forefront of this, you know, glutenase prototypes was this company Alvine, but unfortunately, the last clinical trial Alvine failed during phase 2. So now there are alternatives, they are being exploited, but there's, you know, again, a little bit of alt there. In terms of gut barrier, there is an zonin antagonist. I told you zonin is the molecule that increases gut permeability, is the one that is in phase 3. There are immunomodulators that have been considered to try to mitigate the immune response, but they are not being further, you know, exploited. Vaccine development, so in other words, to make the immune system to, you know, do not react to, you know, the presence of gluten. NextVax was the front line. Unfortunately, the phase 2A failed. So there is an alt there, but there are some alternatives that are considering. Then there is this huge group of immunosuppressants. They're mainly indicated for refractory celiac disease, so I'm not going to discuss here because, as I told you, this is not pertinent to pediatrics. There are enzyme cocktails that are considered, but again, these are only adjuvant for that doesn't really go to the pathogenesis of the celiac disease, you know, immune response, rather, you know, in terms of the consequence and the symptoms. There are in the pipeline some TTG inhibitors that are considered, but they are preclinical, as the preclinical are the HLA-DQ2 blockers. And then finally, there are probiotics. They are in early stage development, again, with the idea to have a double effect to ameliorate the increased gut permeability, but at the same time to dismantle, you know, gluten. And finally, gluten sequestration. So in other words, polymers that can sequester gluten, they are in early phase 2 development. So there is a variety of pipeline products, some more advanced than others, that are really in the making. So there is clearly an ongoing, you know, effort there. So what is my final message in terms of this part of the discussion here? That the gluten-free diet is not efficacious as we thought before. The burden is extremely high, and therefore a lot of patients, they really want treatment options other than the gluten-free diet. The first adjuncts probably will be adjuvant to the gluten-free diet, but ultimately the people, they want the prevention or cure. And in that sense, you know, I'm going to touch upon it with the prevention because this is premise of pediatrics, given the fact that, you know, we know that genetics and gluten exposure must be involved in the pathogenesis of celiac disease, and this interaction between us and the environment imply that there is a maturation of this, symbiotic relationship, particularly with the ecosystem in the gut, the microbiome, that can be altered by a variety of variables that are antibiotic use, feeding regimen, the genetic of the host, the environment, and so on and so forth. And of course, bottom line, there is a lot of effort to try to understand how the gut microbiota composition and function may affect the destiny of kids that are genetically predisposed to celiac disease, because it looks like that is because of those composition of the gut microbiome, you can switch from genetic predisposition to clinical outcome. And this is not a peculiar celiac disease, by the way. There's a lot of stuff that, has been considered in terms of, the presence of or absence of specific microorganisms can really favor or prevent the march from genetic predisposition to clinical outcome. There is now, we are in a major learning curve, so to speak, in terms of to understand, what's going on here. So, of course, knowing that this interaction between gut mucosa and the microbiome plays such a big role, we know that, the bacteria inoculum and engrafted and birth, it's important, as important as the diet, the use of antibiotics, and so on and so forth. But, in terms of, what to do, what we can do to manipulate the microbiome in general for a variety of chronic inflammatory diseases, there are many things that can be done. And of course, you will hear after me, Professor Winter, to talk about microbiota transplantation as a way of intervention to modulate this. We are working on a large study that now is really in its, mature stage, called CDGEM, that stands for Celiac Disease Environment, Microbiome and Metabolomic Studies. There is a study of a birth cohort of 500 kids that we followed from birth, a risk for celiac disease. And the idea is to develop multi-omic analysis to understand what it takes genetically and environmentally to increase the risk to develop, celiac disease on a specific genetic background. Because only by doing this, we may eventually understand why some kids will eventually take the wrong turn and develop celiac disease. And therefore, we may eventually find that some targets for intervention. For example, our preliminary data suggests that if we follow longitudinally these kids from birth, there are specific microbial species and pathways and metabolites that increase way before the onset of celiac disease. They are linked to inflammation and autoimmunity. So months before that these kids, they got sick, we can see what's going on in their gut ecosystem and their metabolic pathways that may say, this kid in 6 months, in a year, in 3 months would develop celiac disease. Other that show that there is a decreased abundance of protective, microorganisms. And finally, we find some strains that never been reported before that can be specific for celiac disease. These are all possible targets, possible microbes and pathways that can be biomarker for future autoimmune disease that can be used for interception and primary prevention in kids that are genetically predisposed. That's the holy grail. This is the premise of pediatrics. That's what we aim for. I'm going to finish again by thank you all for inviting me to this course. My only regret that I'm not physically in Riyadh, but I hope that, there's going to be opportunity in the future. And again, this is the crew of people that, have been involved in all the studies that you heard that, brought us to a level of knowledge that was unimaginable a few years ago. And again, thank you for your invitation.
Thank you very much, Professor Alessio. Very interesting subject, and at least we can see that, or we can say that there is some light at the end of the tunnel. People are working because we are really being grilled all the time in clinic about what else apart from gluten-free diet by patients, and I'm sure your talk will generate a lot of discussion, and hopefully we'll see the results of your recent study in the near future. Thank you very much. It is my pleasure to introduce our next speaker, Professor Harland Winter, who is a professor of pediatric at Harvard University Medical School, and he's also one of the leaders in the field of inflammatory bowel disease in children. He had his basic degree at Boston Children's Hospital, and he went to has become a faculty in the Massachusetts General Hospital, and then he became the lead of the inflammatory bowel disease in children. He has got enormous contribution to the field of pediatric gastroenterology, including many trials in finding the appropriate treatment for inflammatory bowel disease, and more importantly, he had many novel genetic mutations in the field of early onset diarrhea in children. Professor Harland, welcome, and the floor is yours.
Well, thank you very much. Let me see. Can you see my?
Yes, it's there. Yes, we can see it. You can just put it on a presentation.
Yeah, I just.
Excellent.
Okay, it's in the presentation mode.
Yes, excellent. That's good.
Okay, great. Thank you very much. Well, thank you very much for inviting me to participate in this course. And as Alessio said, I think we're both sorry that we're not able to be there in person with you. Last year, I was reminded of the meeting that we had and the wonderful meal that we all had together. And we'll have to have a virtual meal this year, but thank you again very much. So I'm going to talk about fecal transplantation, and this is a topic that has gained a lot of popularity for many different conditions, from inflammatory bowel disease to irritable bowel syndrome to treatment of enteric infections. People have thought about using it in children who have autism and other neuropsychiatric abnormalities. So there's a lot of discussion about this, not a lot of evidence that it works. But let me go through where we are with C. difficile, with irritable bowel syndrome, and with inflammatory bowel disease, and then I'm going to end with discussing a paper that just came out this month, like 2 weeks ago, that was published in Gastroenterology, where it's a phase 2 study using not fecal transplantation, but using the microbiome as a treatment. So whereas a fecal transplant gives us hundreds of thousands of species, these new targeted therapies, which are just being investigated, may be more promising because they're going to provide targeted bacteria that may alter the microbiome and may alter the relationship between the microbiome and the host, because that's really what's relevant is how does the immune system live with this ecosystem that's in our GI tract. And when the ecosystem and the immune system get into conflict, we end up with inflammation, and that may be related to Crohn's disease or ulcerative colitis, or it could be central nervous system inflammation that some people think is relevant in autism, or it could be related to the microbiota and the relationship in celiac disease that Dr. Fasano has pioneered in terms of looking at the prospective aspects of the development of celiac disease in terms of how the microbiome might be triggering these events. So let's talk about C. difficile, because this is really these are really the data where the most is known about efficacy of fecal transplants, because as most of you know, fecal transplantation is highly effective for treating C. difficile. So there's a registry that was just published again this month in Gastroenterology, and it's a registry of FMT, fecal microbiota transplantation, in patients who have C. difficile infection, CDI. I think what's important about this registry is that it's a real-world registry. So it's not, these patients are not part of a clinical trial. They've been treated by gastroenterologists throughout the United States who agreed to enter de-identified data onto an online platform, and the data that they collected, involved FMT protocol, baseline patient data, the cure and the recurrence rate. I want to adjust my screen so I can see this. The baseline patient data, and they also looked at cure rates and recurrences, and they looked at both short-term and long-term safety data. And again, this is real world data, and I think it has a value in that sense. So all the FMTs were done to treat C. difficile. Almost all of them, 96%, were obtained from an unknown donor. So they were all obtained from a stool bank, which some of them were single donors, some of them were multiple donors. About 98% of almost all the patients only received one treatment with FMT. And of the patients who were followed for a year, so those patients that we have for a 1-year follow-up, only 4% had recurrent C. diff infection. So it's a highly effective therapy. At 1 month after the fecal transplant, 2% had diarrhea and 2% had abdominal pain. The side effects, the adverse events are pretty low. And at 6 months after the fecal transplant, there was a new diagnosis of irritable bowel syndrome and inflammatory bowel disease were made in one patient each. So there were some patients, less than 1% of patients, who the C. diff could have been a triggering event for irritable bowel syndrome or for inflammatory bowel disease. So if you look at the data from this study, about 200 patients, or about 90%, were cured. 10% failed, and you can see that the initial failure was about that same rate. About 96% remained cured after a year, and there are about 4% of patients who continue to be a failure, or the others responded to retreatment with an FMT. So there was a very low percentage of people, about 98%, who eventually responded to FMT. The safety profile, as I mentioned, was excellent. So for reasons that are not clear, the FMT is highly effective for the treatment of C. difficile. Unfortunately, the happy news ends at this point because, at least for now, and there's some data that I'm going to look at with you in terms of C. difficile and IBD, because this always comes up. We have a patient with IBD who's having a flare, and their C. diff is positive, and is their flare caused by C. diff, or is their flare caused by a flare of inflammatory bowel disease, and the C. diff is just along for the ride? So some of these patients will have a positive PCR or a positive metabolic test for C. diff, but their toxin will be negative. So if their toxin's negative, they probably don't have active C. diff causing the inflammation in their intestine. But if they do have toxin and they have IBD, then one's obligated to really treat the infection with vancomycin as the first line of choice. We really no longer recommend Flagyl or metronidazole to treat C. diff. You can use either fidaxomicin or vancomycin as a primary treatment. But there's an interesting study that was just published in the past 6 months from the Brigham and Women's Hospital that looked at outcomes of fecal microbiota transplantation in patients with inflammatory bowel disease and recurrent C. diff infection. And what is known is that the prevalence of C. diff infection in patients with IBD is about 8 times higher than that found in controls. And there's also, not only is the incidence higher and the prevalence higher, but also there's an increase in recurrence and an increase in mortality in these patients. C. diff can induce an IBD flare, and that can certainly increase disease activity. One needs to look at the toxin to see if that's positive in these patients as a way of helping sort that out. But in retrospective studies involving patients with IBD, FMT failure rates were about 25 to 30%. So it's compare that to the 98% success rate, or a 2% failure rate in C. diff. in IBD, FMT failure rates are around 30%. And patients who have IBD and C diff are more likely to fail FMT. So this study looked at subjects who had IBD and greater than 2 confirmed infections with C. diff in the past 12 months. And they did a single FMT with a colonoscopy. They used a pooled donor source from Open Biome, which is pooled from 4 donors. And this is important, and we'll talk about the issues related to donors in a minute, because the donor can certainly make a difference in FMT transplants, not just in IBD or in response to an inflammatory disease, but also it's been used in patients who have other conditions. And there have been reports of patients who received a fecal transplant from a morbidly obese individual. The donor was morbidly obese, and the recipient of the fecal transplant started to gain significant amounts of weight. So clearly you can transfer more than just the microbiome to the host. The primary outcome in this study was failure at 8 weeks, and people who failed their initial FMT received a second one. So there were 50 subjects in this study, 15 Crohn's disease and 35 with ulcerative colitis. At 8 weeks, there were 10% failures, and all those individuals who failed at 8 weeks really failed in the first week. So it happened early on in the course, and all failures were retreated, and all had resolution of C. diff. So the C. diff responded to the treatment. So, but the ulcerative colitis or the Crohn's disease did not. And so FMT was thought to be safe in patients who have IBD, that there's a high likelihood of achieving decolonization with C. diff in patients who have IBD, and that patients' treatment with FMT at the time of the second C. diff infection may result in better outcomes. One of the enrollment features of this study was that patients were enrolled after their second C. diff infection. Oftentimes, people will wait until their third or fourth recurrence before offering a patient FMT for recurrent C. diff. I think that the evidence from this paper suggests, especially in patients who have inflammatory bowel disease, that if we have a patient who didn't respond to medical treatment after the first treatment with antibiotics and has IBD, that one might think about using FMT at an earlier stage of treatment. So what about patients who just have IBD, who don't have evidence of C. diff? Well, again, there's a nice study that was published at the end of a little over a year ago, with suggesting that the case reports are encouraging, and so the literature is full of case reports. A lot of them from an investigator in Australia, Dr. Barodi, who's a pioneer and a champion of fecal transplants for a number of different conditions, among them inflammatory bowel disease. And the data from the retrospective studies suggests that the higher the number of transplants that the individual gets, the longer the remission. But when you look at open label studies, so not case reports, but open label studies, the results are not as encouraging. And there really are only 4 randomized controlled trials. And they suggest that the results were best when stool was administered through a colonoscope. And a meta-analysis of these 4 studies showed that more patients in the FMT group achieved a clinical remission when compared to controls, and the controls received autologous stool. And you can see the numbers, 42% versus 23%. So you're talking about a modest increase in efficacy. And most importantly, the outcomes may in fact be donor specific. We need to get more information about donors and the relationship between the microbiota that are transplanted and the microbiota of the host, because the host microbiome may be critical to the effectiveness and the durability of the FMP. And unfortunately, all these studies differ in how outcome was assessed. So there's not a uniform protocol that will allow us to compare and contrast studies. Patients with irritable bowel syndrome have also been considered for fecal transplantation. And there's a study that was just published again a couple weeks ago in Gastroenterology, which is the newest information, that they did fecal transplants in patients who had refractory irritable bowel syndrome, and they received a single dose through a nasojejunal tube, or they received autologous stool. And 12 weeks after the transplant, a little over half of the subjects who received the donor stool improved, compared with about 25% or a quarter of the subjects who were given the placebo, which is the autologous stool. Some of the observations were that women tended to do better than men, and patients who had bloating as a clinical symptom seemed to respond better to FMT. The fecal samples from responders had a higher microbiome diversity prior to FMT. So it may be that the host microbiome may play a role in the success of the treatment. Interestingly, 1 year after a single FMT, only about 20% of the patients who received the donor stool reported benefit, compared to 5% with placebo. So there doesn't seem to be a robust persistent benefit from the single dose FMT in irritable bowel syndrome, and also they didn't identify any specific taxa that were associated with response, which is something that we need to look at, because FMT, you're giving thousands of taxa, and having a more targeted approach would certainly be better. And I'm going to talk about that just at the end. So in ulcerative colitis, where most of the work has been done looking at FMT, firmicutes, which are one of the major groups of bacteria in the colon, produce metabolites that maintain the intestinal barrier and also support, in a positive way, mucosal immunity. Firmicutes are reduced in the intestinal microbiota of patients who have ulcerative colitis. So one of the rationales and hypotheses is, well, if you give firmicutes, can you treat the ulcerative colitis? So this paper that was just published again in January of 2021, and you can see that all these articles are in gastroenterology, and this area of research and investigation is exploding. I mean, there were 4 or 5 articles on fecal transplant in this month's journal alone. But there's a microbiome preparation called SER287, which is a formulation of firmicute spores. And this formulation of, so this is a refined FMT. This is taking a specific population of bacteria and giving it to patients with ulcerative colitis, on the rationale that patients with ulcerative colitis have decreased firmicutes, and that the decreased firmicutes are what are contributing to the ongoing inflammation. They preconditioned the patients with vancomycin, which is an important observation, because it may be that the vancomycin also was beneficial. And they did find that vancomycin preconditioning was associated with clinical remission. So this trial, which is a phase 1b trial of daily dosing with this firmicute spores, had engraftment and clinical remission in about 40% of patients who received the preparation, and none of the patients who received placebo had a response. And so they were able to demonstrate that these spores led to engraftment of the species in the colon, and that there were other metabolic changes that occurred in microbiome function that may be related to replacing this bacteria, which is thought to play a role in the pathophysiology of inflammatory bowel disease. To my knowledge, this is the first really paper of using a form of FMT to treat a condition. And I think this is the beginning, I think, of a new era as we learn more about the microbiome and its relationship between the host immune system and chronic inflammation, that we might be able to target the therapy, much in the same way as we used to use corticosteroids to treat inflammatory bowel disease. Well, corticosteroids are a broad treatment that impact on multiple levels of immune function. And now we have targeted therapies such as anti-TNF therapy, anti-IL-12/23 therapy, and smaller molecules that target specific pathways in the immune system rather than this global downregulation of immunity. So lessons that are learned from FMT and gaps in our knowledge, and I think this is, as I mentioned, this is an area that is dramatically changing on a monthly basis. That FMT is highly effective for treating recurrent C. diff. The donor stool has a metabolic impact on the recipient. The most striking example is patients who have gained weight when they've received an FMT from a morbidly obese individual. I'm sure there are other metabolic impacts that we need to assess, and we'll need to learn those. We don't understand the relationships between the taxa and the response to FMT. This recent article suggests that there is a relationship, and that certainly does make intuitive sense. The benefits of FMT in IBD at this time are really marginal, but there's promise on the horizon as we begin to understand in more detail the relationships between the microbiome inflammation and the host immune response, and how the microbiota can in fact modulate the host immune response. So at the present time, I would not recommend FMT for IBD unless the individual is part of a clinical trial, but that targeted microbiome therapy is clearly on the horizon and is in our future. Thank you.
Thank you very much, Professor Winter. It was a great presentation, and it's always FMT is a very interesting topic wherever you go and wherever we talk about IBD and IBS and C. diff infections. I'm sure we will get a lot of more questions, and let's start with the questions. I think the first question is for Professor Alessio. If we don't have good response to gluten-free diet, what should we do?
It's a good question. As I told you, at the moment, there's this special diet that we call gluten contamination elimination diet. It's been published. It's a 3-month diet in which you can only eat a limited amount of food that is naturally gluten-free, and the intent is to eventually calm down the immune system so that eventually the inflammation goes away. This works most of the time in pediatric patients, but needs to be done under the supervision of a knowledgeable nutritionist and the dietitian. In very selected cases, we use budesonide, but these are very selected cases in which you definitely want to use an anti-inflammatory process, of a pill that you open actually, so that will be affecting the high upper GI tract. And that's, again, something that we typically do for a limited time to give some time to the immune system to, go back and react the way they're supposed to.
Excellent. Another question is regarding the diabetic with high TTG levels. Would you prefer to do a scope or genetic testing before, or just follow up?
So, one of the conditions that can give false positivity for TTG is type 1 diabetes. So the current guidelines is if you test somebody with type 1 diabetes with TTG and is positive, is to reflect with the anti-magnesium antibodies. And if those are all also positive, but the titers are low, and the genetic here doesn't help that much because the HLA for celiac disease and type 1 diabetes highly overlap. An endoscopy is necessary to confirm the diagnosis.
Sure. And another question for you, Professor Alessio. Again, I think the line of the first question is asking about diabetic patients who doesn't respond to treatment. What would you do? Would you give steroids, and how do you tell the family?
Yeah, this is the most difficult category of kids that we have dealt with celiac disease, because as was mentioned before, these are kids that they already are a very restricted diet, because of diabetes. And the gluten-free diet, tend to be an upper glycemic diet. So it's not really compatible with the gluten-free diet. But, even if they stick to the program, sometimes they continue to have symptoms and they continue to have problems, and an affected intestine can also jeopardize the glucose homeostasis, and therefore, how much insulin you have to give to these kids and so on and so forth. In extreme cases, you can use budesonide in a situation like this if there is clear proof that, celiac disease is ongoing, that the enteropathy is still there because you repeat an endoscopy just to make sure that, everything it's under control and you see there is still damage.
That's great. A question actually from myself to Professor Winter. In the old days when we used to have problems with graft versus host disease in BMT transplanted patients, we used to have a unique protocol of using extensive antibiotics prior to the transplant. So we call it gut sterilization. And we put patients on TPN for 2 weeks before prior the BMT. And then the question comes as to how do you populate the gut after the transplant? What would you use? Some people suggested probiotic because of the risk of probiotic, obviously, in BMT patients. Would, from the recent studies using vancomycin in those patients helped or made much difference? Would it be an option to try to use antibiotics prior to fecal transplant and see what happens after that? And would that be an option? I think you are on mute, Professor Winter.
Thank you. Yeah, I think that many of the studies that look at FMT use vancomycin as a pre-treatment. And there's some discussion about whether or not the response that people have is related to the vancomycin modulating the microbiome and making the environment more receptive to the transplant or not, because there are. So it's important to have, like in the study that I quoted from the Brigham, to have a control group that only receives vancomycin, because vancomycin, we use vancomycin to treat ulcerative colitis in many patients. So we use that as a treatment with the idea that it modulates the microbiota and has the potential of downregulating the inflammation. So I think antibiotics do play an important role in pre-treatment of the disease.
Sure. And on the same line, would repeating the most of the studies use FMT as one dose, and then as you know that as time goes by, the effect of the transplant will wear. Would it be reasonable to try to use multiple FMTs, and if you are using that, how often?
Yeah, well, I would discourage people from using FMT as a treatment for inflammatory bowel disease, with the exception of C. diff. And with C. diff, I mean, most patients will respond to one treatment. Some will respond to a couple, to the second dose. But I would discourage, outside of C. diff, I would discourage using FMT as a treatment. I have seen patients end up in the intensive care unit because parents decided to go to some clinic where they're doing FMT, and they ended up with bacteremia and a septic-like picture. So I think one needs to, at this place and time, I think we don't really have enough information to be able to recommend FMT treatment. And unfortunately, a lot of patients think this is a benign therapy. It's like it's no different than going to the bathroom, and so they look at it in that light. But it really the relationship between the host and this ecosystem that has co-evolved with us as a species is right now a mystery. And it impacts on many different aspects of our life and on our metabolism, and we're just starting to learn that now. I mean, we're just starting to learn that relationship. I mean, I think the study that Dr. Fasano is doing, with celiac disease, is going to have not just a lot of benefit for patients who have celiac disease, but I think it's going to uncover a lot of mysteries about the relationship between this ecosystem and the host, and the immune system and our metabolism, because worms have more genes than humans do, and I think we're a higher functioning species, although I do wonder sometimes. But there's a reason why we have this very highly sophisticated microbiome, and when we start to tamper with it in ways that we don't know, we can only cause more trouble. I don't know, Alessio, if you want to comment on that or not, but
I agree 100%. I believe that targeting the ecosystem has tremendous potentials, but we have to learn to walk before that we run, and we are in the process of crawling right now, trying to understand how to manipulate the microbiome.
Right. Professor Winter, a question about the role of FMT in intestinal pseudo-obstruction, bacterial overgrowth.
Well, that's also a tricky question. I mean, because bacterial overgrowth, you're talking about small bowel disease by and large, because there's so many trillions of bacteria in the colon. It's hard to imagine an overgrowth situation. Although in the small intestine is really where you're dealing with that. And there's very little information about the role of manipulating the small bowel bacteria. We did a study looking at this in patients with autism, looking at the microbiota in the duodenum of individuals with autism, and it wasn't very enlightening. I mean, I think that that we don't know a lot about it. So I would be hesitant to think about using FMT in a patient who had small bacterial overgrowth. One would think about using an antibiotic if they're having symptoms, but I would not think about using FMT.
Sure. Professor Alessio, this question I think is not complete, but I can complete the question. It's somebody asking about a child with high celiac screening markers and had twice scope, and both of them show MARSH one by two different histopathologists. What would be the recommendation in terms of treatment? So high titers, two biopsies, both of them showing MARSH1, and by different histopathologists. What would be the recommendation?
So by definition, this would be in the category of potential celiac disease. So that you have high markers, possibly genetic compatibility. We don't know in this case, but let's assume that that's the case. But the enteropathy is still normal. I want to stress a couple concepts that probably needs to be outlined here. While in the past we had the general rule that this disease progressed from proximal to distal. So the worst scenario is in the bulb, and then the duodenum, the first, second, third part, and then going down, decreasing in density, and was homogeneous. Now we know that it's not the case. So you can have patchy lesions, and for that reason, we recommend always to randomly take biopsies, 3-4 biopsies from the duodenum, a couple of the bulb, just to have the chance to not overlook anything. And again, the lack of a histological, damage doesn't rule out necessary celiac disease, because you can be in this potential, part of celiac disease in which you have the symptoms maybe already there. Definitely you have to have the serology, otherwise you don't think about celiac disease, and yet the histopathology is not there. I start to see in the literature also some papers that eventually use a video capsule endoscopy, as an additional tool that, suggests that there are cases in which there is no damage in the proximal intestine that you can identify by histopathology, but eventually it's more damage more distally. That's very difficult for me to grasp this concept, because, the highest concentration of gluten is at the very beginning. That's the reason why typically the damage is there. But nevertheless, there are this evidence in the literature coming up, and therefore, there is an entire possibility that while you do the endoscopy, in which the process at the most proximal intestine is spared, there are distal parts that they have damaged, and in this case, you miss it by doing a typical endoscopy. So all this to say, if you are highly suspicious for the disease, in other words, you rule out everything else, there is no other explanation, there is family history, the HLA compatibility is there, the serology is there, a negative, endoscopy is not a deal breaker. Consider potential celiac as a possibility.
Excellent. Thank you very much. There are more questions, but I think we run out of time, and I'm sure people can reach out for both Professor Fasano and Professor Winter. Thank you very much for a very nice presentation and very nice discussion. And the floor back is to Professor Asiri.
I would like to thank Aliso and Harland for this excellent update. I would like also to thank Dr. Ruba for the excellent update on pancreatic islet cell transplant, and hope to see all of you on site in Riyadh next time. I would like also to thank my colleague, Dr. Ali Mehedib, for being a moderator of the first session. And I would like to thank a brother of mine, Dr. Ma'amun Al-Awad, for accepting this moderator as a moderator in a short time. I wish a very good health for Dr. Sharifa Al-Ghamdi, whom she is also one of our colleague in Sussegan, but unfortunately she got severe laryngitis and lost her voice, and she gave apology for being not with us tonight. I would like also to thank all my colleagues in Sussegan and the Department of Pediatric and head of the Pediatric Gastroenterology Unit and the chairman of Pediatric. Thank you all. See you tomorrow. Tomorrow, inshallah, we're going to have Professor Nikhil and Dr. Jonathan Hind. It's going to be a short session because tomorrow is a weekend and everybody will be busy with his family. Thank you all and see you.
Thank you.
Thank you. Bye now.
My sincere thanks is also extended to Dr. Mudathir and Dr. Muhammad Kambal and our moderator, Dr. Hani Timsah.